Thanks, Josh. Good afternoon, everybody. I'm Amy Gorin. I'm the director of InCHIP and wanted to take just a quick moment to welcome you to this semester's lecture series. We're really excited about the offerings that we have this semester, kicking off with Dr. Carter's talk today, and encourage you to check out our website for the full listing of our lecture series, as well as many different trainings we're having this semester, both for graduate students in our Lunch and Learn series, talking about career routes outside of academia, all the way to faculty who are thinking about mid-career K awards. So hope you can join us for some more events this semester. I'm going to turn it over to Dr. Rick Gibbons, my colleague, who is going to introduce Dr. Carter today. Thanks, Rick.
Hello, everybody. I am very pleased to introduce today's speaker, Dr. Ciara Carter, who is an assistant professor of psychology at Georgia State University. Very quickly here, she received her Ph.D. in clinical psychology from the University of Georgia, where she worked with a colleague and good friend of mine, Stephen Beach and Rita Walker. And while she was there, she was introduced to the Family and Community Health Study, and she has been a junior member of that team, and hopefully a member of Next Gen Facts for the last 3 or 4 years. She has numerous awards and recipient of several grants. In terms of the award category in 2019, she received an award from the Congressional Black Caucus for being one of 40 researchers under the age of 40 who are leaders in mental health research. She, as I indicated, worked with Steve Beach and continues to work with the group, including being the recipient of a Diversity Supplement Award for an NCI grant. And hopefully, as I said, she will continue to be working with us for quite some time to come. Ciara?
Thank you so much. Yes, I will do that. Thank you so much for that introduction. And I'm going to go ahead and share my screen. All right, so thank you so much for having me here today to share some of the research that I've been doing and working in collaboration, like Dr. Gibbons said, with the Family and Community Health Study, as well as some other future directions that I'm planning to do in collaboration with that group, as well as some other groups, and understanding how we think about racial trauma and racial health disparities among Black American populations, with the specific focus of this research currently in examining what pathways we can take to healing, collective action, and liberation. I wanted to start by just first giving a brief overview of what I plan to talk about today. I want to start off with just a brief background of some terms, some terminology, some history, so that we're kind of all on the same page. I'll then talk about some of my past and current research focus and how different forms of research that I have done have impacted where I'm currently going and where some of my colleagues are going in this area of research, particularly in considering and really focusing on racism as a chronic stressor in Black lives. I'll then talk about health disparities linked to racism and trauma exposure and this conceptualization of racial trauma. Then I'll move a little bit into intergenerational impact and open to questions about that. I think we have a lot of areas to grow in that area. And then lastly, I'll talk a little bit about strength and liberation for some of our current work, both qualitative and quantitative, and thinking about how we can move towards health equity, particularly for Black populations. And I'll end with some take-home points. So I like to start my talk with this picture from a magazine, particularly around when the Black Lives Matter movement after the brutal murder of George Floyd happened. And oftentimes when we talk about movements and activism, we think about specific time points. And George Floyd was one of those. But when I think about racism, I think it's really important to note at the beginning of this talk that racism has been alive and well for a very long time, in the United States in particular. And that has led to a number of ways that we can think about historical legacies of oppression in Black lives, including the killing of Sandra Bland, Ahmaud Arbery, Freddie Gray, Trayvon Martin. The list goes on, sadly. And also, I think what's important, what you'll see in the screen, is not only are we thinking about police brutality, but we're thinking about broad killings that have roots in oppression, including the murder of Martin Luther King, the murder of Malcolm X, and how living in this space, living in this world here in the US for Black people has been this long-standing history of oppression. And it didn't just begin with George Floyd, but has this long-standing history. I also like to note from this story is that this story is not only a history of oppression, but also a history of survival, adaptation, and thriving. And so I think an important note to think about is what have Black people had to do to combat with these continuous legacies of oppression? And that's something I also think about. So it's not only the surviving, but it's also how can we promote Black people living longer and even more thriving lives within the system that we're living in the US. And so one of the things that we know is that racism is a chronic stressful stimulus, but people weren't actually acknowledging this as long as we think, and aligning it with other things that we consider to be chronic stressful stimuli. So I wanted to put at the bottom of the screen some of the scholars. This is not all of them, but some of them that have really influenced how I have learned about this work when I was an undergraduate as well as today, and understanding the ways in which racism is insidious. Dr. Joel Sorrell discusses how racism is a pervasive stressor that may get under the skin and into the mind. And as a clinical psychologist by training, but also in the community psychology program, one of the things I think when we think about the multi-level constructs of racism is not how mental and physical health are dichotomous. And that's important to the work that I do. We know that stress related to racism-driven injustice is embedded within the fabric of our US society. It's multi-level and can have multiple ways of impact. There's also been a term that I'll talk about a little bit later in the talk, defined as racial trauma, and there have been scholars, including Dr. Robert Carter, Dr. Janet Helms, Dr. Tama Bryant-Davis, who have really thought about how racism is traumatic. But in the 1990s, Dr. Janet Helms began to talk about why she thought constructs like racial trauma weren't in our contemporary trauma research, theory, and practice. And she says that the broad historical foundations of racial trauma and its developmental effects often are sufficiently diffuse and pervasive that they do not provide objective evidence that a particular individual has been harmed more than others. And when she said that, she was acknowledging that, one, that racism can be hard to measure in some incidents when we think about it's not only the individual's experience, but all of these systems and structures that have impacted the individual, as well as communities, to perseverate on the mental and physical health of their lives. But she also makes a point of how important it is to study this multi-level impact and to acknowledge that racism is a consideration of how people don't live as long as they deserve to live. And so I think that's an important consideration. It's like, just because it might be hard to measure, Janet is pointing to we need to, or we could be missing something. So for this talk, I'll define racism and racism-related stress specifically as race-related transactions between individuals or groups and their environment that emerge from the dynamics of racism and that are perceived to tax or exceed existing individual and collective resources or threaten well-being. Now, when we think about what we're living in today, we still have a pandemic going on, but researchers have also begun to say that racism is a pandemic as well. And we also know, just like I had mentioned before, that this is a long-standing and life course experience of a chronic stressor from racism. So we know that Black youth experience higher levels of racial discrimination relative to youth from other racial and ethnic backgrounds. And nearly all Black youth in some research studies report experiencing at least one racially laden discriminatory incident in the past year. One thing is also important to note is that Black people are not a monolith in experiences of oppression, and that also has influenced the work that we do, as well as some of the other research scholars of thinking about when we experience racism, there are different ways that people perceive that experience as well as how they live with it. And we still have a ways to go and really examine the biological embedding of racism-related stress from a life course perspective to really think about ways of intervention as well as prevention. So now I want to talk a little bit about trauma, which is already an acknowledged chronic stressor. But research also suggests that African Americans may develop PTSD at higher rates than white adults, and that clinical course of PTSD is poor. Now, when they say poor, what they mean by that, and what current research is showing, is that African Americans who do participate in treatments for PTSD do get better, but they're getting better at a slower pace than their white counterparts. It's taking longer. And so there's been some consideration of what that can mean. We also know that African Americans have significantly higher rates of objective life stressors, such as witnessing violence, all the way to receiving bad news, and losing a loved one prematurely. And we can think about what that could mean in COVID, when particularly Black Americans are disproportionately impacted due to the effects of COVID. Concentrated disadvantage, particularly in urban communities, places Black people at disproportionate risk for exposure to violence and trauma. So hopefully you're beginning to see the particular interwoven nature of these types of experiences. We also know that almost 65% of African American youth report traumatic experiences compared to 30% of their peers from other races. And theoretical models of early childhood adversity have largely neglected the multifaceted influence of multiple forms of traumatic stressors on mental and physical health outcomes. And Dr. Dante Bernard recently came out with a theoretical paper saying racism may serve as a unique role in explaining why Black people are disproportionately exposed to trauma. So I like to give this image of McEwen's model from 1998, where I like his model because I think it kind of shoots at where I think our research goes, as well as where I think the field is going and thinking about stressors and chronic stress and its impact. What I like about his model is you can see that at the top of his model, he talks about a number of different stressors: environmental stressors, major life events, trauma, and abuse, all of which are defined as these chronic stressful stimuli. He also talks about how the mind and the body are connected. So when you experience one of these chronic stressors, what happens, right? You have a cognitive reaction, so you perceive that stressor, and you also have a physiological response to that stressor in order to survive. And so when that stressor is acute, our body is naturally reacting to support itself, to reach a balance, but also to respond to the stressor. So our body responds. We can have a fight or flight response, and our body is responding into that stressor so that we can get away from the stressor, a natural response and an adaptive response. But McEwen also notes that when that stressor doesn't end, or is a prolonged stressor, then that can lead to our body not being able to reach this feeling of safety or balance called homeostasis, which leads to what we call as allostasis, where our body is having this dysregulatory process that can lead to some of the chronic illnesses that we disproportionately see amongst Black populations, including things like metabolic disease like diabetes, hypertension, and cardiovascular disease. Now, Mays and colleagues said in 2007, hey, wait a minute, there's another stressor that should be within this model to consider. And if we consider racism and this as a chronic stressor stimuli, then we can also consider how particular groups, and in this case, I want to argue Black groups in particular, disproportionately experience all of the stressors noted in this model. And what does that mean? We not only are experiencing racism, but racism is also interwoven with the other stressors that are noted to be influencers in health disparities research. Now, when we also think about racism and its multi-level effects, we also know that racism is embedded in how we think about other types of inequities. So what is residential segregation in our history here in the US? Where does it come from? And when we think about concepts such as redlining, When we think about concentrations of poverty and violence and the policies that impact people who disproportionately live in those areas, we can also think about how racism is embedded in those constructs as well. We also know that they are linked to this higher allostatic load, which is also linked to disproportionate rates of chronic illnesses. So I'm going to move into some of my work, but I wanted to start with a quote as I move into these studies. So Ta-Nehisi quotes, when I was reading his book, Between the World and Me, says, "It struck me that perhaps the defining feature of being drafted into the Black race was the inescapable robbery of time." And as many of you probably know, I'm going to talk a little bit about accelerated aging, so our body responding to these stressors and aging faster than it needs to. And I was like, this is perfect. This really aligns with the research that I do. But then as I kept reading, he goes a little bit deeper into what that could mean. And so he says, but the price of error is higher for you than it is for your countrymen. And he's speaking to his Black child at this time. And so that America might justify itself, the story of a Black body's destruction must always begin with his or her error, real or imagined, with Eric Gardner's anger, with Trayvon Martin's mythical words, "You're going to die tonight," and with Sean Bell's mistake of running with the wrong crowd. So what he's picking up on and what he is stating to me, in my interpretation, is that Black people aren't allowed to make mistakes in the same way that majority cultures are. And when you're living in an environment where you're constantly thinking about ways to survive and adapt, what does that do to the body, right? So not only is it that this is an accelerated aging process, but it's a mind process as well of how do you work in a world that's not meant for you? And I think that's an important thought process of the work that we do. So I want to start with one of the first studies I want to talk about is the effects of early racial discrimination on accelerated aging among Black Americans. And as mentioned before, this is with the Family and Community Health Study, was part of my dissertation work, and examining the role of depressive symptoms in the relationship between early life experiences of racial discrimination at age 10 for Black youth and accelerated aging in adulthood. So this is over a 19-year period after adjusting and controlling for gender and other health behaviors. I'll get into some risk and resilience factors that we looked at after the fact, but one of the good things about the Family and Community Health Study is it's a longitudinal study, so it gets at this kind of life course perspective of understanding the impact of racism. And it also is including mental health and not separating it out from these physiological outcomes, such as accelerated cellular aging that we collected through blood draws. So briefly, one of the key findings that we saw here was that racial discrimination experienced by Black youth at age 10 was significantly related to accelerated cellular aging at age 29. So aligning with this model of weathering, but also how racism can be embedded in body regulatory systems that can impact Black people's lives over time and into early adulthood. And so this accelerated aging process is also linked to chronic illnesses that we can see, including hypertension, cardiovascular disease, et cetera. But one of the most interesting things that I think is an important thing to talk about is one of the mechanisms that we found driving the relationship between racial discrimination and accelerated cellular aging was depression. So it got us to thinking a little bit more about what does it mean to experience racism as a kid? And what does that look like in thinking about your life? Things that feel and are uncontrollable, persistent, laden in this thing that there's no way I can control what's happening to me. And that influencing depression, right? And we know that not everyone in our study who experienced racial discrimination went on to develop depression. And that made us think about what are some of the qualities, some of the thoughts from a clinical perspective that offsets that cost of experiencing racism that can lead to depression. But also, what does depression mean? So a second study that I worked on was really thinking about depression and what it means. So we created a combined measure of adult maladjustment that included depressive symptoms, but also included a measure of poor self-control as well as low self-confidence. Because we were thinking about what the process was that influences racial discrimination to depression and maladjustment broadly. And we did find that link, and we did find that same relationship with accelerated aging. But we were also looking at socioeconomic status, because we were wondering if there are some qualities, not only thinking about individual level factors, but some more broader level factors that could influence this relationship as well. And what we found was actually opposite of what we thought. One of the things that we found was that Black youth who came from higher socioeconomic status, so had more higher levels of income as well as living in a more prosperous neighborhood, were more likely to show that link between racial discrimination to adult maladjustment, including those measures of depression, self-control, and self-confidence. So they were more likely than the individuals who were lower in socioeconomic status to have that higher elevation. I'm happy to discuss that during the discussion, because we're considering ways to conceptualize that finding. So when I finished that study, one of the things that I was also interested in was what other types of health disparities are not solely and completely linked to socioeconomic status, because we know that racism and poverty are interconnected processes, but we know that also racism is unique in some ways from poverty. And so one of those factors that I've been exploring more here lately is maternal health and morbidity among Black women. The primary antecedent of infant mortality is low birth weight. And unlike some other health disparities, education and income is not necessarily the primary factor influencing poor trajectories in maternal health. One of the studies that really stuck out to me was a finding that said that babies born to college-educated Black women are still more likely to have a lower birth weight than babies born to white women who dropped out of high school. And so we began to do a brief review looking at studies that look at the biological embedding of chronic stress across 2 generations within marginalized communities. One of the things I'll note is we found a research study looking at anything that kind of looks at racism as a biological embedding process across generations. There were only 11 studies that considered racism kind of in the pregnancy journey, in birthing populations, discussion of how racism can become biological embedding and affect this health disparity. So the research is really small. And so we created a kind of a model thinking about racism across the time of pregnancy, but also when the baby is born, thinking about how even before a Black person enters the world, the impact of racism could be affecting the fetus, and it's affecting the Black pregnant mom. And what does that mean when you're already before you're even born? This could be affecting your livelihood and your ability to thrive. And so we begin to think about factors, including individual level factors, community level factors, structural level factors that need to be examined further, and how we can think about the intergenerational effects of racism. And I think there's a lot of research to do that. But similar to how we saw McEwen's model, we're believing that racism should be considered in this disparity, and how racism can be biologically embedded and affect the fetus, but also the lives of Black youth and Black children across time. And so there hasn't been a lot of research on this, but one of the things I want to notice, as also a trauma researcher, one of the things that I notice when I go to trauma conferences is we talk a lot about the Holocaust. Importantly, we talk about the intergenerational impact of the Holocaust on the offspring and next generations, affecting both their anxiety levels of offspring later and even currently today, descendants from the Holocaust, how that has affected some PTSD symptoms disproportionately experienced by that group. But when I'm sitting in those meetings, I begin to think about, like, why do we not talk about slavery or enslavement in this conversation? And so there is this concept called post-traumatic slave syndrome by DeGrow, who argues that decreased self-esteem, even ever-present anger, and racist socialization are the psychological markers for post-traumatic stress syndrome, and explain intergenerational family discord and the numerous disparities in health outcomes. when this book was written by Joy DeGruy, she talks a lot more about the cognitive implications passed down across generations to survive a horrible time of enslavement, right? What messages are passed down across generations that promote survival? And I'm happy to discuss that later. But I think there's also room for more research to really discuss what the biological and physiological implications of enslavement were for Black populations. And so in some of the work that we're doing, happy also to discuss that later, mostly qualitative work and qualitative interviews with Black women have led to some intergenerational discussions. And I'll put this quote here. One of our participants said, "My mother told me as a child that I could expect to be harmed by the Black men I loved because they've been traumatized and hurt too." I think that really stuck out to us as something to really think about when we're thinking about not only things like police brutality that Black men may face as well as Black women, but how these things work when we think about violence perpetration, as well as the embeddedness of what it means to think about who is getting harmed disproportionately and how we think about trauma. So that moves me into some of the other research that I'm doing in conceptualizations of trauma among Black Americans, which leads me to this discussion of racial trauma or race-based trauma. So one of the findings recently in 2018 found that racial discrimination was associated with 70% of trauma-related symptom outcomes. And there's this term called racial trauma. You might hear it in different ways, but race-based trauma, where Carter defines it as dangerous or frightening race-based events, stressors, or discrimination that overwhelms one's coping capacity and impacts quality of life, and it causes fear, helplessness, and horror. Now, if there are some trauma researchers in the room, you can think about how that relates to our DSM-5 diagnostic manual's definition of a traumatic stressor. I like to say that there is a choice made about what can be considered traumatic in our diagnostic manual, and this has changed over time to include other forms of traumatic events that weren't included before. And this is the DSM-5's definition that I'll briefly just show here, but I won't read. So researchers have begun to say that racism can be considered a potentially unique type of stressor and traumatic experience because of its historical legacy in the US and multi-systemic effects. When I was a trauma clinician at the Atlanta VA, as well as at the Grady area, that I'll talk more about that research in a second, I had a Black male client who talked about his experiences of trauma, who has had a lot of what we call traditional trauma, violence exposure, as well as some sexual assault experiences for himself. And we were talking through some of those things one day, and he noted that being Black, my traumas don't end. And it really stuck out to me as a clinician, but also as a researcher, but really thinking about what is the consideration for racism as traumatic and why don't we consider it? And what are the implications when we do? So there are different ways that people have thought about racism as traumatic or shouldn't be fitting in our diagnostic manual. And there is a camp that says racism is not an individual pathology or disorder. We can all agree on that. And that shouldn't, for some groups, that shouldn't be considered in how we diagnose or think about treatment. But then there's another group that said racism needs to be recognized and acknowledged for treatment in order to have the most efficacious treatment for those who disproportionately experience these types of oppressive stressors. So researchers have, for a very long time, talked about racism as traumatic and have said it's important to note that we are not categorizing normal responses to racism as disordered. Similar to rape and domestic violence, racist incidents are the problem and are the root of the disorder. People should not be stigmatized as problematic when they are responding to emotional and sometimes physical assaults to their integrity. And post-racism distress is a normal response to an abnormal experience or a sane response to an insane stressor. So I think there's also a lot of work to do in this area. And understanding the lived experiences of Black people requires a racial health equity lens and a historical consciousness in order to understand how these things are interconnected and intertwined with each other. And so the same client that I had said, This was around the time that Eric Gardner was killed. And we were talking about this case and how distressing it was for him. And he noted also that some of us did not die like Eric Gardner. We're still here. And when he said that, he was talking about how these incidents of police brutality rooted in oppression, as well as the incidents across of oppression, these aren't highly publicized events in his community. And they're experiencing them, and it's not something that's noted or conceptualized or thought through as something that can affect both mental and physical health. I'll briefly just say that we already know, and there's research to show that racial discrimination is related to all PTSD symptoms, including avoidance, hypervigilance, arousal, negative mood and self-esteem, re-experiencing intrusive symptoms, as well as other things that we consider when we think about our trauma literature and its relation to things like sleep difficulties, depression, somatic symptoms, irritability, and anger, as well as concentration problems. So this work that I'm about to share here is really thinking about examining the influence of stress related to both our traditional forms of thinking about trauma as well as racism in functioning health behavior, physiological responses, particularly in populations with high rates of trauma exposure, as well as poverty. So I wanted to share some preliminary findings done with with a group called the Grady Trauma Project here in Atlanta. It's a large-scale study looking at risk and resilience to PTSD and trauma-related disorders, primarily in Black populations. One of the key important notes about this study is this is a non-treatment seeking, mental health treatment seeking population. They're going to their primary care appointments, and we are asking if they will be interested in doing a trauma interview. This has been going on since 2005. So there's more than 13,000 people who have come through the Grady Trauma Project, including conducting clinical assessments as well as blood draws. I will also note that amongst this population, primarily Black population, the socioeconomic status is primarily related to poverty. So there's an interwoven nature of lower socioeconomic status as well as experiencing of other forms of oppression. One of the things to also note is amongst the Grady Trauma Project population that has been studied is that exposure to multiple forms of trauma is the rule rather than the exception. So generally in our US population, the average number of what we define as criterion A traumas, or things that could be diagnosed for PTSD, the average number of those experiences, including sexual assault, car accidents, all the way to violence and exposure to violence perpetration by a gun or weapon, the average number of experiences is 1 in a lifetime. For this population, the average number of experiences of these criterion A traumas is 4. We also know amongst this population that trauma exposure often includes this life course experience of both childhood abuse and other types of family violence across the life course. So again, the importance of taking this life course perspective of thinking about how trauma can affect someone across their lifespan. So I wanted to just note here, there is a study that has looked at childhood trauma exposure amongst Black youth ages 9 to 12. And you see all of these high rates of trauma exposure, including witnessing assault, the child being assaulted themselves, threatened with a weapon. But one of the things I noted when I was working at the Grady, I still work there, but as a postdoc, was what does it mean when a Black youth reports witnessing arrest if we don't consider racism as a part of the picture, right? So we see these high notes of witnessing arrest, but when Black youth are reporting this, they are talking about arrest by maybe their father, who has, when we think about racism, who was brutalized by the police with that experience and then witnessing that. So we're not necessarily contextualizing oppression in the experiences of trauma, which I think is something that we're missing. We started to think about culturally relevant factors, and I'll go into, so you don't need to see all of this at once, that could be influencing the relationship between racism and trauma symptoms. I'll start with thinking about racism as a multi-level factor, and I think we still have a lot of work to do in this area. So this is preliminary work. But I wanted to point you to this finding with cultural racism. So not only is racism related to hyperarousal symptoms, intrusive symptoms, and avoidance and numbing symptoms that we see with PTSD symptoms that could relate to a post-traumatic stress disorder diagnosis, cultural racism is one that sticks out to me as something that I think we need to explore more. And I put in the box here one of the examples of the questions of cultural racism. So you notice that when Black people are killed by the police, the media informs the public of the victim's criminal record or negative information in their background, suggesting that they got what they deserved. So it's not only the person's individual or interpersonal experiences of racism, but also what it means for Black people to see people that look like them experiencing racism and killing on our TV screens. Another area of research that I think is important for us to continue to work with and work about. And then another area that I have also been interested in exploring more here is issues of racial identity. And so we've seen across racial identity measurement that it is also related to racial discrimination amongst the trauma-exposed population. But I was really interested in this item of racial identity called public regard. Often when we think about racial identity, we think about racial centrality, so how central being Black is to my identity as a Black woman. But Robert Sellers, when he conceptualized this measure, he talked about it as a multidimensional construct. So not only is it about how central it is to me being Black, but how I think other people view me as being Black is important as well to my racial identity development. And what we find is that is related to a number of the racial discrimination measures that we're measuring right now. Now, what that could mean is that the way that I think other people view me influences the way I experience racial discrimination experiences, as well as the way I experience PTSD symptoms, which I think is an important contextual point of thinking about culturally grounded ways of considering identity in the process of trauma exposure as well as oppression. So I think we have a lot of ways to think about the interwoven nature of racism and trauma, both at the interpersonal level, but also broader, right? We're living in a time where Black people and Black youth are watching videos of other people being killed that look like them, as well as seeing that in their communities. And these conversations that Black parents might have to have maybe earlier than they want to when Black kids are asking these questions about what is happening in this video that I'm watching on my tablet, on my cell phone, and how stressful that can be for the parent as well as for the child. And when we're thinking about trauma-exposed populations, these conversations about survival, adaptation, I think there are important considerations to think about when we also think about Afrocentric ways of healing as well as processing. So I like to say one of the things we consider with African American populations is that African Americans can be collective, right? If we go back to our roots, right? So if we collectively felt the killing of George Floyd, which led to protests and activism, the response to that or the intervention likely is going to have to be collective as well. So collective traumas are going to need collective interventions and collective thoughts for healing. And I think there's ways that we can consider that even more broadly. So I've been working a lot in this space and thinking about ways in which we can think about PTSD and interpersonal trauma and racism and the interconnection of those two. And it's been a really interesting journey to really consider these interconnected processes that can affect physical health down the road, as well as physical health down. Recently, we've also started to consider amongst the Grady Trauma Project group the ways in which racism can affect brain functioning amongst this trauma-exposed population of Black Americans. And this particular study was done among Black women. And this is a preliminary study of about 55 Black women who were doing fMRI brain scans. All of this was originally related only to our traditional thoughts about trauma exposure. So those traditional criterion A. We didn't look at racism as a particular factor. But one of the things that we found is that racial discrimination above and beyond trauma exposure, so we control for trauma exposure, was highly related to brain networks related to threat processing in the brain. And that was something that we found really interesting. But what we also found was that that wasn't the whole story. So while they were in fMRI, they were doing an attention task, which was looking a little bit at attention control, kind of like a Stroop test. And I can explain more later. And Black women were less likely to make errors if they had high levels of racial discrimination on these tasks. So it wasn't necessarily that this was all bad, right? Because they were able to attune to the task and have high levels of attention control. But this taxing of threat processing, we can think about in this weathering process also, what does it mean to always have to be on guard and always have to be thinking about potential threats? Again, the quote about not being able to make mistakes. The last study that I'm going to discuss is introducing biomarkers into understanding this biological embedding of racism and trauma and the interwoven effects of both. And so we begin to think about reliable stress biomarkers that are linked to inflammation. So in McEwen's model, this inflammation that is influencing allostatic load. And one of those measures is what we are looking at, is cell-free mitochondrial DNA. And it can really is a good measure of inflammation of body regulatory processes. So one of the preliminary findings here is when we consider both racism and trauma, it leads to some potential interesting findings. And these were interesting to us as we're considering to continue to look at this even further. So the TEI that you see in this graph is trauma exposure inventory. And so we broke it up into low exposure to trauma exposure, low trauma exposure and high trauma exposure, but looking at it in relation to racial discrimination. And what you see in that third bar is for those who are reporting high racial discrimination, but low trauma exposure, are showing the highest cell-free mitochondrial DNA reaction, so the higher inflammation. So what happens if you don't consider racial discrimination in your trauma research or in other types of research where you're utilizing diverse populations, Black populations, and not considering oppression? And this again highlights how we could be missing an important feature of how racism works and how racism is embedded in the process of inflammation and should be considered and is considered a chronic stressor. So some of our future work is to continue to examine these biomarkers, as well as some other physiological assessments in this area as well. So in the last couple of minutes, I want to talk a little bit about strength and liberation and a movement to health equity. So with Dr. Gibbons, I wrote a paper looking at the biological embedding of racial trauma in the research literature in this area. And I started off this paper with a quote from Angela Davis, just saying that if we don't know how to meaningfully talk about racism, actions will move in misleading directions. And I'll take that even further. Our interventions and preventions will move in misleading directions. And so one of the ways that I think about this is from our qualitative research findings of thinking about liberation and healing, but also thinking about listening to Black women and listening to Black populations about their experiences. So when we talk to Black people in our communities, they're saying a lot about what's happening and what they want. And so here are a couple of quotes from them. Black women in hospitals are treated like Black men with the police. There was a study that said Black people don't feel pain. We both expressed something to our doctors that was ignored. We both know that hospitals are known for killing people. I kept telling the white doctor, because I had an infection in my finger, I kept telling him something was off about the medication he gave me. And he gave me morphine 3 times and mixed it with Benadryl. And then it was a Black nurse that was like, something's not right here. He, the white doctor, kept saying I was fine, and so I had to be rushed to the CPR room. I honestly felt like I was going to die. And so when thinking about these qualitative work that we've been doing, but also the work that needs to be done, it's often in the research literature, from my research as well as others, is we often preclude contextual considerations. We do a lot of research that's either race-based or non-race-based stressors, but not the interconnection of the two, which I think is an important consideration. We also have a lot of work to do in considering the place that racism and trauma experiences hold in social power structures in our society, and really thinking about the structural impacts of racism and the power that is happening when Black women in particular experience racism and trauma. So a lot of our work is kind of thinking about Black womanhood and not only the effects of sexism, but racism and trauma exposure on health outcomes. And then that begins us to think about, what does Black liberation look like that serves both the mind and the body? So during Breonna Taylor's verdict, where the police were not held accountable for their actions of killing Breonna Taylor, there was a lot of uproar. We were doing focus groups at this time. And one of the things that I found was, and we discussed with some of our focus group participants, is like, what did you do in response to this verdict? And one woman said, I went out and protested. And then I went to my clinician and I had a therapy session. And so we began to think about the different ways that activism and collective activism can potentially be healing, along with not separating out the need for healing, maybe of therapy. And there's maybe a combination approach that can happen that we want to explore even more, thinking about what Black people do in response to oppression that is longstanding, and you have to act in thinking about ways that you can affect change and not pathologizing that as something that could be helpful. We also are looking more into resiliency. So with that finding I reported earlier, with the higher SES Black youth showing this greater link to racial discrimination, from racial discrimination to adult maladjustment, we're beginning to say, what is optimal resiliency? And there's some research in this area kind of looking at what it means to succeed against the odds as a marginalized or minoritized person when you're living in an environment of oppression. Does that come with a cost, right? Physically. And I think there's a lot of room, and some of our work is kind of looking more into the need for healing spaces for Black people and what that could look like that serves the mind and the body. And this isn't new research, so I just want to say briefly that a number of scholars have talked about radical healing and liberation that serves both the mind and the body, is rooted in Afrocentric practices, including holistic practices and anti-oppression strategies and strength-based practices that really focuses on what Black people want and how they can heal themselves. And there's a radical healing framework that also is starting to align with some of the research I shared before about ways that we can think critically about interventions that really serve Black people, Black people, and as well as the mind and the body, and how that might look differently from a collectivistic standpoint, right? So if I'm experiencing not only racism myself, but also seeing it, and that is also stressful, then that likely is going to need both resistance strategies as well as social support strategies and ways to feel like I can be myself and have healing spaces for myself. And so I'll end with thinking about where our work is going and also where radical healing can go in this space. And I like this quote, there's an unrealistic expectation for young people to break generational curses while still operating in the system and culture that created the curses in the first place. And so Dr. Melissa Creary talks about this bounded justice, and this is something I'm working around right now, how it's impossible to address health equity when the infrastructures underlying them are eroded by racism and historical oppression. So possibly that the Eurocentric values and boundaries of our systems, as well as our clinical settings, are limited in their ability to actually affect change, and that these interventions need to be set in the communities that we want to serve, and in order to consider the multiple layers at which racism works. So take-home points. I really believe that healing is going to require recognition. If you got anything from this talk, is really thinking about racism as a chronic stressor. And in order to address racial inequities among Black people, we must acknowledge the trauma experiences for this population are rooted in multi-systemic oppressive context. When we do this acknowledgement, we can consider more racially equitable, both clinical as well as policy-based solutions to address racism. And I still believe that there's this life course perspective that we need to continue to do that looks at intergenerational, as well as from youth to adulthood, the effects of racism, to really think about what are these optimal ways that we can think about intervention and prevention approaches. And still, given our current social political climate and U.S. legacy, it's important to think about novel ways to intervene when Black people are experiencing higher levels of PTSD symptoms and ways to promote Black healing as well as thriving. So I just wanted to briefly say thank you to all of my colleagues who have helped with this work, including the Center for Family Research and the Family and Community Health Studies specifically. I want to thank the Grady Trauma Project as well as my team at the Heart Lab for all their help with this work as well. And that's the end. Thank you so much.
All right, thank you, Dr. Carter, for such a wonderful presentation. Certainly very thought-provoking presentation. So thank you. So now we're going to move on to the Q&A. We have a couple of minutes for questions. So we're going to invite all the participants to bring your questions. You can either write them in the chat or you can use the raised hand function, and then I will call on your names as I see them. So I see, let me see. Alexa Sanson is a question. Oh, sorry. Okay.
I saw that.
She was just applauding. Okay.
Rick, you're on mute if you're asking a question.
Okay. So in terms of long-term effects of racial trauma, brought to mind some of the work that Jean Brody has done on the John Henry effect. Can you tell us a little bit about that and how that might fit with the research that you've done?
Yeah, so we've been thinking a little bit about not only John Henryism, but kind of the strong Black woman schema as well.
Mm-hmm.
Kind of in line, if the audience doesn't know too much about that, kind of John Henryism is based, the John Henry folklore is based on this person who was working really hard on a train tracks, and then died from all this hard work that he was doing. And there's an even further story of how Black people who worked hard, really hard to make it, and can show high levels of self-control and a number of other things, how that can be helpful to reach certain goals, including college education and other types of outcomes that we typically look at, but physically can take a toll. It can influence health. And we see similar effects with strong Black women schema in some ways, which is also looking at how Black women have to be everything to everyone, right? And how that can take a toll. And so a lot of our questions, COVID has impacted this a little bit, is we're asking Black people how they define resiliency, but we're having them hooked up to a physiological measure while we're asking them about the stress of racism and trauma. So skin conductance, heart rate variability, as well as a continuous blood pressure monitor to ask, like, what has that experience looked like for you? And ways that they have coped, so that we can understand what is that possibly doing to the body physically. Is there ways that have coping that work better for some Black people, but not for others, both for the mind and the body? So we're taking measures of mental health as well as physical health to get a broader picture of, like, is there a way to think about ways in which we can intervene that promote what Black people are experiencing and saying as their ways of thinking about being resilient in the space of oppression. So that's the way we're kind of thinking through that process.
Thank you. I see that Sharon Casavan has her hand raised, so you can go ahead and unmute yourself and bring your question.
Thank you for such a great presentation. This is so timely for me. And I was wondering what made you choose the cell-free mitochondrial DNA as a biomarker. Were you simply interested in the inflammation? Yeah, if you could answer that, I'd appreciate it.
Yeah, so some of this is also interdisciplinary work. So I was working with a biologist, actually, and we were talking about, like, ways that which we can really understand how inflammation processes work. And she was like, do you have blood samples? And I was like, yeah. And she was like, well, in mouse studies, which we're not doing, but, like, she was like, we think about this from this standpoint. And when we were discussing it, it led to that collaboration of saying, well, in her mindset, this mitochondrial, cell-free mitochondrial DNA is getting at this process of inflammation that can really be a more stable biological marker than maybe others.
Interesting.
And so we began to kind of look down that road. But I'm open to understanding more. But I think it was kind of this collaborative work of trying to understand kind of biology from the standpoint of racism too. Yeah.
That's super interesting. I would love to connect with you offline.
Yes, I love that picture.
Thank you. To see if there's any more questions that come up. Somebody did ask if it was possible to share the slides. Just so you know, the presentation is being recorded and it will be on the YouTube channel, so you can watch it again. All right, it seems like we don't have any more questions. Oh, never mind, we got one. It was a question from Tamia Thomas. She asked, are there any interventions or strategies that you suggest to combat with racial trauma at the school setting?
So that's not my research specifically. I'm interested in it, but actually some of my colleagues, we've been talking a little bit about that. Dr. Farzana Salim is much more in school settings than me, Rihanna Anderson with youth. And they talk about using these culturally grounded perspectives that I touched on a little bit, kind of racial socialization practices, racial identity, and talking with teachers about the processes of oppression that's happening in school settings, but promoting messages that really promote Black youth's resistance to school setting oppression. And so I think there are ways that people are talking about and thinking about, including Dr. Christy Bird, to really focus on school settings and oppression. I think each system takes a unique approach, including carceral systems and other medical systems. And I think there are many people kind of working at different angles to really approach those settings. So that's a really great question. I think there are people who are working on, particularly using culturally grounded mechanisms to approach school system oppression.
Thank you. There's another question in the chat. Forgive me if I mispronounce your name. From Tunisia. She was wondering, they're wondering if there are any doctors or groups in the hospitals interfering in the racial health disparity.
I don't know broadly, but I think it's been a bit, both from a policy level in our Congress, but also here in Atlanta. One of our grants that we have been proposing and talking to our community advisory board on has been talking to medical providers about racial health equity, as well as perpetuation of racism that can affect birth outcomes for Black women. And that has been an interesting journey with the community advisory board, because one of the things that I had to check myself on, I'll be honest, was a discussion around, we already know that we experience racism, but do the other people know how they perpetuate it? And so that is something that we're kind of moving into the space and acknowledging that they're right, that there needs to be more interventions that is not only implicit bias training that we see mixed evidence for, and really thinking about ways to approach the systems and the structures that perpetuate the inequity. So I do think that there are spaces that I see requirements, at least in our Emory clinics and Grady clinics, around implicit bias training, but we don't necessarily think that is as effective as we think from our personal experience. And so we're thinking about other ways informed by the community that we can engage in interventions.
Thank you. I think we're gonna pause here. We've reached the end of our time. Thank you so much again, Dr. Carter, for this wonderful presentation. We greatly appreciate your time and your scholarship. Everything that you've brought today is just wonderful. And again, like I said, super thought-provoking. So we greatly appreciate your work, and just thank you.
Thank you so much.